Salud, Florin. Good evening, Florin. Good evening, everybody. Welcome. We are almost 100 already. Good evening, everybody. Oh, hello, Bahamas. Very, very, very far from Bucharest. Nice to have you here this evening. Good evening. Take your seat. We will start in a few minutes, but I think there are also some colleagues that would like to join. So as usual, we will wait for about 5 more minutes and we will start very soon. We are more than 100 people right now and still coming. Hello, Macedonia. Nice to hear from you. Welcome, everybody. Make yourself comfortable and prepare for at least 2, maybe 3 hours of endodontics. Slovakia. Hello, Julia. I'm very happy that there are a lot of people from almost all over the world. I will just share a little bit the screen. And this is what is going to happen tonight. Welcome, Bulgaria. Very nice people here. Dentistry is the same all over the world. And the fact that you all are here tonight, this is actually the proof for that. Good evening, Ovidio. Nice to see you again. Hello, Greece. Very, very nice country, especially during summertime. A lot of us like to spend holidays in Greece. Hello, Poland. I'm very happy that you are here. You are not the only Polish here. Oh, greetings from USA. I can't believe that. Welcome. I'm very happy that I have all of you here this evening, and I hope we will make together a wonderful evening and a wonderful lecture. What time is actually in the part of USA where you live? Hello, Croatia. Nice to have you here, Eva. Hello, hello, hello. Bruxelles. Very nice. Hello, Laura. It's 2 o'clock p.m. Nice. It's 9 o'clock in the evening, Bucharest time, and I think for most of you it's 8 or maybe 7 o'clock from the people living in Europe. Hello, Florin from Sweden. Very nice. So, guys, until we are going to start, I just want you to present as usual Dr. Dariusz Miszkiewicz from Poland. He is the representative of KaVo Care, and he's the guy that this evening will make everything goes perfect. So if you have technical problems, please just write them in the chat window, and Dariusz, I'm sure he will deal with them very efficiently. From time to time, you will see that Dariusz will make some written announcements. He will, you can see his name is Monika Milewska there, but actually is Dariusz with us tonight. If you have technical problems, or if you want, for example, to know something about the recorded version of this webinar, you can ask Dariusz. Actually, at the end of this webinar, all of you will automatically receive a link through email, and at that link you will find the recorded version of the webinar. So if you have technical problems tonight, or if you cannot stay so late in the night, or if you just want to review some parts and to listen more carefully to some stuff, you will just have the link in your email, and you can you can watch this webinar again. Also, please look into the spam folder, because it is possible that the email with the link will go there, and you have to know that everybody that were registered in this webinar will receive that link. So also please check the spam folder. Dariusz, would you like to say a few words to the audience before we start?
Good evening, everyone. It's a great pleasure to host this meeting for you. It's a great pleasure to see Dan again, just because it's his fourth webinar, and I hope you will enjoy it as the previous ones. I wish you a nice webinar, and hear you soon. Thanks a lot.
Thanks a lot, Dariusz. Do you think we should wait 2 more minutes, or we should start right now?
I believe that we should start.
We should start. Great. Then I will start the presentation. We are almost 150 now, and I'm sure that more people will be here soon. So as you probably noticed in the announcement, today we are going to talk about root canal filling. And as the title say, it's just pack and go. By this title, I just meant, or I just wanted everybody to understand that root canal filling, it's not such a complicated procedure that most of our colleagues believe. And the idea is that if you took care that everything was performed as good as possible, as well as possible, until the moment of the root canal filling, then everything would have to go very easy and smoothly. So you will notice at the end of this presentation that things are not so complicated if we follow some very easy rules, very easy steps but you will find more information during this webinar. One more organizatoric thing. If you have questions, please just write them in the chat. I will take a look from time to time in the chat window, and I will try to answer those questions. I would have only one request, and it is very important. Please try to address the questions just related to the subject, to the topic, and to the information that I discuss about during that moment. Because otherwise, if I will stop for answering questions that have no connection with the moment of the webinar, then the structure of the presentation will not be so logic anymore. But please feel free to ask questions, and from time to time I will take a look to the chat window. If there are too many questions and you see that your question remained unanswered and it disappeared from the screen, please just make a copy-paste procedure, and for sure I will see that question and I will address to it. Darius makes a comment right now that the webinar is being recorded, and for sure you will receive that link as discussed previously. So now let's start to talk about root canal filling. I mean, just pack and go. If you carefully read the title, probably you anticipate that we will talk a lot about vertical compaction and continuous wave technique. But what is important is that during this webinar, I will address to almost all root canal filling techniques known on the market. Of course, I will not talk about those techniques that were used like 100 years ago and they were using some paste, some sealers and only sealers, but I will address to all modern techniques that are still accepted, and I will about some of them I will discuss a little bit more. You will see that talking about other techniques, I will just mention a few things and that's it. And of course, I will explain why I decided to talk more about some of the techniques and why I just say a few words about the others. For those that followed my last webinar, that was almost about 2 weeks ago. It was also a webinar hosted by KaVo Care Company. We discussed about the recipe of successful treatment, and we had like a 10 easy steps protocol about root canal treatment. And if there are people that did not want to, did not have the occasion to follow that webinar, and you think that's interesting for you, you can just type in the chat window that you want to receive the link for that webinar, and I'm sure that Darius could tell you what you have to do in order to be able to also watch the other webinar. Regarding the lecture this evening, we will talk about this 9th step, like proper root canal filling. And from the beginning, I want you to notice that this is just a step. This is not the treatment itself, but it's just a step. And if you understand this concept, then you will understand that looking to an X-ray where we can see a root canal filling performed yesterday or maybe performed like 10 or 20 years ago, it's not enough in order to say something about the whole treatment as it was performed. we can just say something about the root canal filling itself. And yes, today we will just talk about this ninth step, the root canal filling, but please follow all the clinical steps, all the correct clinical steps in order to be able to deliver a predictable root canal fillings. So what we are going to discuss today, we are going to understand why we actually want to fill the root canals. Because if we understand why we have to do a procedure, then we will understand easily how to do it correct and what to expect about that procedure in the end. And after that, I will try to present a little bit what's going on in the day-to-day practice. Actually, what first motivated me to adapt this topic and to talk about it, because you know, people are just performing root canals following some protocols, but maybe not all protocols are so actual, or maybe some protocols are not suited for, let's say, dentists with experience. Maybe some of them are just dedicated to students in order to better learn the procedures. And that's why I want to just discuss a little bit what I find in my day-to-day practice when doing some retreatments relative to the root canal filling, and what I think we could improve in order to achieve better results. And then I will present you what root canal filling techniques we will discuss. And we will talk about like 5 or 6 different root canal techniques, but especially I will address to 2 of them. The first one is the single cone technique, and the second one is continuous wave technique. Maybe some of you would have expected that the 2 techniques that I will address will be lateral condensation and vertical condensation, like continuous wave. But as you can see, the lateral condensation of cold gutta percha is missing from this slide. And when I will talk about this lateral condensation, I will explain you why I will not discuss it into details. But still, after exposing my ideas, if you feel like you really want to ask some questions about this root canal filling, through lateral condensation technique, please feel free to ask this question. And then we will talk about some devices that we use with some root canal filling techniques. And I will show these devices to you, and I will teach you how to work with them. Not really necessary to work correctly with them, because I'm sure that this one you can learn from any dental book, any book of endodontics. But I will also try to teach you how to use these devices efficiently, because of course we our first desire is to deliver high quality root canal fillings. But the second very important thing for us is that we really want to be efficient in our activity, and we will learn how to do that. And in the end, but not only in the end, I hope that all over my presentation, you will be able to find out a lot of tips and tricks about root canal fillings. And then if we will talk about some mistakes, we will also talk about how to prevent those mistakes that may happen during our procedures, and also how to correct those mistakes. So this is what we are going to debate tonight. And I've told you the length of this webinar will directly depend also about the number of questions that you will address, but prepare for, let's say, about at least 1 hour and a half, maybe 2 hours of discussions. Now, Just one short test. Just tell me how is the sound and the image for you. Just write, a few of you, just write me into the chat window if everything is fine and you can hear and see me perfect. Sound and image perfect, fine. Thank you very much, everybody. This feedback is very important for you, because on one hand I know that everything is going on smoothly, and on the other hand I know that you are here with me. Raresh writes to me that sometimes his sensation is that my microphone is disconnected and then reconnected again. Anybody experiences the same problem, like small interruptions? Yeah, most of you, yeah, also Antonia, have these problems. Friends, I hope this is not because of my connection. I hope it's because of your connection. And if it's not from my connection, that would be perfect, because if there are some parts that you cannot hear very well, maybe you can check the recorded version later, and you can listen to those parts. So why one should fill the root canals? You know that when talking about endodontics, the main objective of the root canal treatment is cleaning and shaping, but actually is cleaning the root canal anatomy. And when we are talking about root canal anatomy, we are talking about main root canals, we are talking about accessory anatomy, and also about the pulp chamber. So these are the parts that should be very well cleaned during the root canal treatment procedure. And after cleaning, we would like that for a long period of time, no bacteria, no liquids from the oral cavity that, of course, can transport bacteria. So those liquids, we don't want them into the endodontic anatomy. And that's why we want to make something like a barrier between oral cavity, or let's say the neighborhood of the tooth. And the possibilities of making this barrier is, on one hand, doing a proper root canal filling, and on the other hand, making a proper coronary restoration. Tonight we are going to talk about root canal filling. And of course, as you can see in those pictures, which of course are not mine pictures, you can find these pictures even on Google. If you just type endodontic anatomy, you can find pictures like that, or in any endodontic book, you can see these images that represents real teeth that were decalcified. So they became transparent, and we can see this purple substance that was previously injected inside the endodontic anatomy. And we can see actually how complex is this anatomy. And if we are looking to those pictures, we understand that, simple root canal filling techniques can manage partially this situation. But if we really want to seal main and secondary anatomy, then we will have to think about some more complicated procedures. I will debate this at a later moment, and I will also try to give a piece of advice about what you should do about the root canal fillings according to your level and according to the pathology that you usually treat in your dental office. From my point of view, you will see that also you can manage cases very well if you adopt simple techniques, but those simple techniques should be performed correctly. In the meantime, I just want to make very clear for you what is the aim of the root canal filling. And no, I will not talk about zootechnical stuff and about agriculture, but this example is very important because what I've noticed from my day-to-day practice is that usually both dentists and patients give too much credit to the root canal filling. So in my colleagues' eyes, the importance of root canal filling is actually much greater than it is in the reality. And I will try to explain you exactly how these things are working, because it's very, very important to make to make proper root canal fillings, but also to understand why we are doing actually these root canal fillings. And if you take a look to this example, where we are talking about sheepfold, where you produce two things like milk and milk derivatives on one hand, and on the other hand you produce wool. But it's not important exactly what you produce. It's important to understand that this is the main result of this job. And people that start a business like that intend to produce milk and wool, and this is the end result. Actually, you have to look to this like the cleaning and shaping step of the root canal treatment, because when we talk about root canal treatment, the aim of this treatment is to clean the root canal. Now, look at these two guys. These two guys here represent the root canal filling. So actually, they don't produce anything. They don't produce wool. They don't produce milk. They don't even contribute from getting this from the sheep. But they are very important because they take care nobody will harm the sheep. There will be no wild animal that can come and kill the sheep. And this is actually the closest parallel to the root canal obturation aim. Actually, the root canal obturation is not so important for the success of the root canal treatment itself, but the role of the root canal treatment is to be sure that in 5 or maybe 10 years or maybe 20 years, the results that we got through the root canal treatment will be still there because we were able to seal the root canal anatomy. And if you want to be more close to the reality, you can consider that this guy from the left is the root canal filling and the guy from the right is the coronary filling. And if you take this as a package, you get the whole image of the root canal filling. This is what we expect from that. And from that point of view, we need to understand that a nice root canal filling is just a nice root canal fillings. It's not a warranty that the whole root canal treatment was correctly performed and also that we expect some nice result from that root canal treatment. And now, why have I decided to adapt this topic? Because from the hands-on lectures that I used to give when we are not arrested at home by this coronavirus, and you have to know that almost weekly I used to have 1 or 2 hands-on lectures where I met with colleagues like us, dentists, and we are discussing a lot of endodontic topics. Well, a lot of you are concerned about how to perform this root canal correctly, and to know what actually are the mistakes, what is considered to be right, what is considered to be wrong, and how we can stay away about these mistakes. And this is the first reason why I decided to talk about root canal filling. And then the second reason, and this is also a very important reason, and it is connected with the example that I gave to you with the sheep fold and the dogs. It happens very often that colleagues that send me patients, let's call them referrals. So the referrals, sometimes they send like, let's say, terminal endodontic cases, like those teeth cannot stay anymore in the mouth. The right indication is the extraction, and it sometimes happens that these extraction cases arrive to my office, and in some cases, even if the indication is the removal of the tooth, you know that there are some patients where we need to do as much as we can just to preserve that tooth, I don't know, for 1 month, maybe for 1 year, maybe for 2 years. For example, elderly patients or patients that have general diseases and they just cannot receive implants, or there are cases when patients receive implants but they need a provisional, and in order to have a fixed prosthesis, then they need one tooth that normally should be extracted at the final dental prosthesis, but for 1 or maybe 2 months or maybe 6 months they need that tooth in order to use it as an abutment. And this is why sometimes we decide to treat some cases. And if you attended the previous webinar where I was talking about root canal protocol as itself, you remember that I said one rule that for me is an eliminatory criteria. If I cannot place a rubber dam on one tooth without any special preparation, excepting surgery or orthodontics, but if we are talking about the build-up, so if I cannot place the rubber dam without the build-up and the tooth cannot follow a procedure like surgical elongation or orthodontic extrusion, then my decision is not to treat that tooth. And then the referral is okay with this idea, and he says, okay, you cannot place the rubber dam on that tooth, but still I want you to fill the root canals because you do it better than me. And this is the moment when I'm trying to explain that making a root canal filling without performing a proper cleaning, it's for nothing. And the patient will pay a lot of money to receive in the end the same result that can be obtained in any general practitioner's office, because I cannot help that patient with the maximum that I can usually do. So my recommendation in that case is that the patient will return to my colleague, and the colleague will perform the procedure, the whole procedure, with the root canal filling itself, because it's just the same result that I could get. So once again, the patient should not spend that money for a procedure that is totally uncertain. And then the third reason is this set of X-rays, where you can see that on every X-ray you can find at least one tooth that has gutta percha in the pulp chamber. And as you know, we are talking about root canal filling. And as its name says, the root canal filling should stay inside the root canals. So one thing that I want to discuss is about how to perform a proper technique. It does not matter what technique we are talking about. I just already told you that we are going to talk more about single cone technique and about continuous wave technique. But there are some rules that apply to any of the root canal techniques. And in the end, I find a lot of cases where patients come into my office with indication of retreatment on teeth that have no diagnosis that recommends that retreatment. For example, let's look into the last X-ray, the molar, the lower molar on the right side of the image. Of course, there is a root canal filling that can be a lot debated. But still, this root canal filling was performed like 20 years ago. And also this root canal filling, we see that there is a patient with quite a good hygiene. He has almost no pathology on the adjacent teeth. And also we can see that there is no periapical pathology. So this treatment was performed actually when the patient was like 13 or 14 years old, and still during this period of time there was no problem with the tooth. So just looking to this X-ray and saying that yes, there is a short root canal filling, the mesial root canals almost they are not filled at all. Of course, there is gutta percha into the pulp chamber, but still these tooth have no pathology. So unless this tooth will perform a complicated, let's say, prosthodontic procedure, which is not the case here, maybe it's not the right moment that the patient will have to spend money and time in order to follow a procedure that in this moment and maybe in the next 10 years he would not need that procedure. And more than that, we know that the root canal treatment itself, it's not 100% successful. In the best statistics, we may hope that we will have a 90% success rate, but we know that the reality is about 70-75%. So if we treat these teeth that actually have no pathology at the moment, and they will have almost no pathology at all, if we are talking about treating these teeth, from the beginning, we condemned 25% of them to failure. I will stop for a moment because Diana tells me that she cannot see the slides. I can also see that there are a little bit blurry, some of them, but I don't know if this is a problem in anybody's case. There are also people saying that they can see the image quite okay. So Diana, maybe it's about the internet connection. I will apologize for that, and please be patient. And if there are some things that you want to, if you want to see better, just take a look at the recorded version. And if you are not satisfied also with that, you can write me in private. I will post at some moment some contact data, and that's valid for all of you. And if you want some, of course, I cannot send you the whole presentation, but if you want some punctual things that you want to better see and clarify, you can write me, and I will not promise that I will answer right tomorrow. But as soon as possible, all of you will find answers. Just to make an idea, after the Romanian version of the webinar, which took place about 4 or 5 days ago, it lasted like 3 hours and a half because there were a lot of questions. And still after the lecture, I have almost 2 days still responded to your questions. So I was very happy that a lot of people were interested about what I was talking about. Dariush says that the recordings are much better. So please be patient, listen to the information, and maybe you just take a short look tomorrow or immediately after the webinar, and you can take a look at the pictures and see the details. So these are the root canal filling techniques that we are going to talk about. Of course, some of them you know better. Some of them maybe you don't know at all, or you just heard about them in the university, or maybe to some colleague. As you can see, I wrote in green color the single cone technique and the continuous wave, because this will be the most discussed technique during the next slides. But I will say a few words at least about all or every single technique that you can see on this slide. And I've told you, if you have more questions, I will be very happy to answer. But before we are talking about different root canal filling techniques, let's talk a little bit about the materials that we use during root canal fillings. And as you probably know, today the most accepted, almost universal materials are gutta percha and sealer, and these two are combined in different proportions and in different techniques in order to get what we call the best possible result. And I will make a short discussion here, because the first question is why we need two dental materials. Actually, you know that during the time there were some tentatives to replace gutta percha with some other materials like composite resins. These tentatives were quite promising in the beginning, but unfortunately they proved to be not so efficient, and at this moment they were almost completely abandoned. So I will just address the gutta percha sealer association, and I will make this discussion in order to better understand what do we expect from these materials. And actually we concluded that from the root canal filling, we just want to obtain a seal, a barrier that will not allow the bacteria to enter into the endodontic space and then to go to the periapical tissues. And this is the reason why we want to close this endodontic space as good as possible. And we know that when we are talking about best closure, we are talking about adhesion. And actually this adhesion, you will see that is the only thing that misses gutta percha, because gutta percha is almost the ideal material for root canal fillings, but strange, it misses the most important attribute that it should have, this adhesion. If gutta percha would have bonded to dentin, then gutta percha would really become the ideal material for root canal fillings, and we would not need to combine this material with something else. But as long as gutta percha cannot bond to dentin, then we need something that bonds also to gutta percha and to dentin. And of course you will say, let's find a substance that doesn't need to bond to gutta percha. Let's find a substance that will only bond to dentin, and that's it. Okay, of course we would like to have such a material, but until now if we are talking about about root canal sealers, we were not able to find such a material or a resin that will satisfy all the conditions. And you know that with this abbreviation, G means gutta percha and S means sealer. And if we are talking about adhesion, I colored the S in the green color because it's much better than gutta percha. But this sealer has a lot of disadvantages, and actually this is the reason why until now we do not have a sealer that can be used just as it is. And the main disadvantages of the most sealers on the market is the contraction. And at this chapter, gutta percha is much better than these pastes that we use as root canal sealers. And I will explain you how this contraction can influence the quality of the root canal filling, actually the quality of the seal, because as I told you, with the root canal filling, we really want to seal the root canals. And this contraction works like that. You have an example here. Let's imagine that we have an object that is 10 centimeters long, and this object has let's say 100 Celsius degrees temperature, and then slowly it's just brought to the room temperature, or even lower. We can bring it to 0 degrees or under 0 degrees. And you know that basically when we lower the temperature, almost all the things in nature contracts. And if we are talking, let's say, about 10% contraction, of course, it's not the case with the sealer. We are not talking about 10% because it will be awful if the sealer will have such a contraction, but it's easier for the graphics. So if this let's say this blue bar will contract like 10% of its length, it will be something like that. And if it was previously fitted to the blue line, like let's say the blue line is root canal wall, now you can see that we have quite a big gap, like 1 centimeter, and through this gap a lot of things can pass. Now imagine that this bar is only 1 centimeter long. And if we keep that 10% contraction, this time we will only have 1 millimeter gap. I think some of you, if you complain about the quality of the image, maybe you just cannot distinguish between the blue line and the red line in this case. And now imagine that these dimensions are not like centimeters or millimeters. Imagine that we are talking about hundreds of millimeters, or that we are talking about microns. If we are talking about so small dimensions, and if we are talking about a contraction rate of less than, let's say, 2 or 3%, then we realize that in the reality, we could actually be able to get a root canal filling that, despite the contraction of the sealer, if the layer of that sealer is very thin, like let's say hundreds of millimeters, then the effect of this contraction, which is not a thermal contraction but it's a chemical contraction, it's a setting contraction, then in that situation the gap will be almost invisible, almost inexistent. So we should not be afraid that some bacteria could pass through that very small gap. And the same happens in case of the solubility discussion, because you know that almost everything in dentistry, almost everything, not everything, but if we are talking about cements and sealers and pastes, everything has some solubility, and at some moment a part of the material that we have in the tooth, in the canals, or in the coronary part will disappear because it will be dissolved by the saliva and other liquids. So there will also be some gaps, and we really want that these gaps will be so small that almost no bacteria or virtually no bacteria will be able to pass through those spaces. And that's why we also like to have a very, very thin layer of sealer during the root canal filling. And in the end, if we are talking about durability and about the necessity of about durity, actually, it's if we want to retreat a root canal that was sealed only with sealer, that will be very difficult or almost impossible in some cases. And that's why we really don't like to have so much sealer into the root canals. If you look to these 4 ideas, all of them, even the first one, even the adhesion, where you see that sealer acts better than gutta percha, even in that case, our aim is to have a very, very thin layer, because we know that every time we have an interface, and at that interface we have a substance like a glue, if that glue layer is very thin, then the adhesion will be much stronger than when the layer of the glue will be thicker. So even the first line, the first idea, where the sealer acts actually better than the gutta percha, even in that case it acts better if it's in a very, very small amount and not in a thick layer. And that's why, remember this when we are going to discuss the other the root canal techniques. Just remember this idea that anytime we really want to have inside the root canal a very thin layer of sealer and as much gutta percha as possible. And now let's talk about this single cone technique. I will not start to describe this technique step by step, because by definition, every dentist should know this technique. Actually, it's the first technique that we learn in university when talking about root canal filling, and in many cases, it's the first technique that any of us performed while we were students. So even if lateral compaction of gutta percha, of cold gutta percha, is much popular these days, single cone technique still remains the first technique that most of us performed in the university, even if we are talking about extracted teeth or in patients. So I will just say a few words about this easy technique. From my point of view, is the easiest technique also to learn, but also to perform in the mouth. And because of this aspect, still I think this is the most predictable technique. Of course, in theory, there are much better techniques. Actually, any other technique in theory is better than single cone technique. But when talking about day-to-day practice, things are not like that, because by its simplicity, single cone technique, as I told you, still remains the most predictable one, while the others are not so predictable, because if they are superior in theory, but it's very easy to make mistakes, and if we cannot perform them as good as possible, in most of the cases, a single cone technique would have been much better in the end. And I will talk about some aspects that I've noticed they are, let's say, not so well understood by my colleagues. And the first aspect that I want to talk about is the overfeeling. I mean, the situation when we try to perform a root canal filling, and in the end you take an X-ray and you see that the gutta percha point is let's say 2 or 3 millimeters longer. Of course, this is not a tragedy. It's a matter that should be avoided if possible. But if it happens, it's not like a tragedy. The let's say the bad aspect of this situation is that somehow it says that maybe that dentist does not master very well the technique itself. And I will not say that the dentist does not master the technique of root canal filling, but actually what happens before the root canal filling. Because if we have an overfilling and it's about single cone technique, in all cases, from my point of view, the mistake happens in the previous steps of the root canal treatments. Actually, it means that the practitioner has not correctly estimated the apical diameter of the apical constriction. And I will not have enough time to discuss this topic tonight, but during the webinar that I had about two weeks ago, I completely covered this topic of apical diameter estimation. So please, if you were present in that webinar, or if you just asked now for the link to see the replay of the webinar, just look for that apical diameter estimation chapter, and I'm sure that you will find there all the information necessary. What I want you to remember now is that if we have overfilled canal, never, but never, it's not the fault of the root canal filling itself, but you have to look the guilty aspect in the previous steps of the root canal treatment. One very common mistake that happens when performing single cone technique is that we do not use appropriate taper gutta percha points. And that means that in the end, we will have a lot of gutta percha, a lot of sealer in the main root canal, and almost no gutta percha. And I will explain you what are the big disadvantages of this option. So even if we practice in university and mostly in the beginning, we are only practicing with ISO gutta percha points, like O2 taper. We need to get used with the idea that we have to be able to provide for a root canal filling also O4 or maybe O6 gutta percha points, and that's why they cannot miss from our dental office. So we really need those gutta percha points with greater taper, because you know that most root canals and most root canal preparation techniques use high conicity hand or rotary instruments. And from that point of view, we need to be able to deliver as long as it's needed to be able to deliver also these kind of root canal fillings. And another annoying part of the root canal filling is that very often we use too much sealer, and that is not good from a lot from many points of view. And I will explain you actually why we are doing that and what is wrong with that. The problem comes even from school, because if we read the books where this root canal filling technique is described, if we are talking about this technique, you know that we have to use lentulophiles, and we are taught to take some sealer, like let's say half of the length of the lentulophile, and then to introduce it into the root canal, and then to take the lentulo out and put another paste quantity and once again introduce it in the root canal. And of course, this manner of doing things was almost appropriate maybe 50 years ago, when actually we did not have greater taper points. We were just using O2 gutta-percha points, and that's why we needed a lot of sealer inside the root canals, because if we did not have enough sealer and we were using so thin gutta-percha points, then the result was that inside the root canal will be voids, and we could not talk about proper seal. But nowadays we have greater tapers when we are talking about gutta-percha points, and the idea, as I told you, is to use very small quantity, very small amount of paste. And if we put too much sealer inside the root canal, like filling actually the main root canal, when we introduce a cone, a gutta-percha point that is almost identical with the root canal shape, I'm not talking here about those root canals that have very big discrepancy between let's say the mesiodistal diameter and the vestibulo-oral diameter. I'm talking about normal root canals where if we get the proper gutta-percha point and you introduce it inside the root canal, then almost all the amount of sealer should be extruded coronary. And imagine that if we use a lentulophile as we are taught in the university, then we will place so much gutta-percha then that in a molar with 4 root canals, we will fill the pulp chamber with sealer even from the first gutta-percha point, and we still need to put paste and gutta-percha in the other root canals. So it will be far from the big amount of the sealer that actually we throw away. We also reduce or we just cancel our visibility, so we will not be able to make a proper root canal filling. And maybe this is one reason for which sometimes you see that the dentist managed to prepare the root canal, but he was not able to introduce there a gutta-percha point anymore. There are still people asking about the recordings after the presentation. Thank you, Darius, for managing that. Once again, as I told you in the beginning, but maybe not all of us were here from the beginning, maybe not all of you. We have here Dr. Darius Miszkiewicz, who administrates this session. And whenever you have technical problems or you want to be provided with some links like this one, just write into the chat, and Darius will manage that very shortly. Now let's talk a little bit about lateral condensation. Probably if you already read what's written on this slide, you can anticipate why I will not talk too much about this method and why I do not recommend this method. It's not because it's not a good root canal filling method. Actually, in vitro, in tests, it proves to be much better than single cone technique, but only if we are studying the sealing, the actually sealing of the root canal system. But in practice, taking in consideration that it's a very, very time-consuming, very much time-consuming technique, we end in doing it not so properly, because if you count that in every root canal, maybe we need to use one master cone and 5 or 6 or maybe 7 accessory points, gutta-percha points, then just multiply this by 4 and you will come to the conclusion that for an upper molar, for example, we will have to spend at least 30 minutes or maybe longer just to make the root canal filling. While if we compare it with the single cone technique, you can finish the single cone technique in, let's say, 3 or 4 minutes from the moment the root canals are cleaned and dried. So that's why I don't believe in this technique, and I do not think we get so much advantage from lateral condensation, so much advantage to justify the time that we spend with this technique. And this time, you know that somebody has to pay this time, and this is the patient or the dentist. It depends if we charge this time or not more than we would have charged it comparing to a single cone technique. So the idea is that lateral condensation still remains a good, a predictable root canal obturation technique. Still, it is a little bit more complicated than the single cone technique. But when we are talking about the productivity, from my point of view, and I think I'm not the only one thinking like that, from my point of view, the time that we spend with this technique is not completely justified by the results that we get. And I was very happy to see some comments on Thursday when I had the webinar in the Romanian version of this webinar. There were 2 colleagues that said they waited for this webinar as a reason to abandon the lateral condensation technique and to start something new, because they felt like this root canal technique is not the best technique for their expectations. So I will pass to the next technique that I would like to discuss. This is also, let's say, an old technique, and I think nobody still practices it like this. But we need to talk a little bit about this Schilder technique, because this is the origin, this represents the origin of actually what we are doing today in most of the cases. But before that, I just want to present you this book. It's called Endodontics, and this is the cover of the volume number 2. I think everybody knows Dr. Arnaldo Castellucci, and I'm sure almost all of them know, all of you know his books. Well, this is the second volume of this endodontics atlas, this endodontics book, and all the images that you will see on this slide are taken from this book, and I just use them to explain you very shortly what means the root canal vertical condensation of worm gutta-percha, or the shorter version, the so-called the Schilder technique. This technique was imagined during 60s by Schilder, and Schilder also noticed that even if lateral compaction, which was quite popular at that time, is a good root canal technique, he actually felt that he would like to have some gutta-percha also in the lateral anatomy. And that was the reason why he imagined this technique, which despite his superior results, it was even more complicated and even more time-consuming than the lateral compaction itself. But still, if you were practicing a little bit and you were trained, you could perform it quite predictably. I myself used that technique for about 2 years when I finished university, because I felt like I don't like lateral condensation, and I just want something a little bit better. Of course, talking about those times, on one hand, I had a lot of free time because I was just finished the university, and I had not so many patients, so it was not a problem for me to spend like 4 or maybe 5 hours for a root canal treatment on a molar or a retreatment. And on the other hand, I had no devices that I could do some other techniques like continuous wave, because on that time, like 15 years ago, everything was very expensive, and the devices were not even present on the Romanian market. It was like 2007 when I managed to buy such second-hand device from abroad. So I had to stay with and to live with this Schilder technique, but it was important for me because I was able to understand the principle of vertical compaction, and then just to adapt this to the technique that I even practice today, and that I will also present you during next slides. What is this vertical compaction about? It's like placing some sealer, like in the first slide with the care file. We place the sealer. We need a very small quantity of sealer, and we place it inside the main root canal. And then we come with the master cone. We introduce it into the root canal, and we cut it with a worm instrument, like let's say a spatula or an excavator, or maybe a black instrument. And after cutting with this hot worm instrument, we are just coming with thick plugger. As its name says, this plugger compacts the gutta percha, and it creates something like a plug here. And then we come again with the hot instrument, and we place it inside the gutta percha core that it's in the root canal. And yeah, it was not for me, it was for Dariusz, an email. He will manage that. So we remove a piece of gutta percha, we compact again with a cold plugger, still coming with a hot instrument, one cold plugger again, and we do this until we reach, let's say, almost the working length. It's the working length without 3 or 4 millimeters. And this is called the down pack, the down pack step of this technique. And as you can see, there are a lot of small steps that we need to cover until we reach the final result of this procedure. And it's quite unpredictable because we use a hot instrument. We don't know how hot it is. We don't know how hot it still is when we remove it from the root canal, and so on. So it was quite a time-consuming and an unpredictable technique. And now it comes the second part, which is called the backpack, when we place very small amounts of gutta percha inside the root canal. We heat them inside the root canal with the hot instruments, and imagine that these hot instruments are just taking from the working field and are introduced inside the patient mouth, just passing nearby the lips, and maybe in the proximity of the dental assistant fingers. So it could also generate some accidents. And in the end, this technique was not so popular among the general practitioners, but there were a lot of endodontists that for maybe 10 or 20 years just practiced this technique, because they considered that it's much better than single cone technique and than lateral compaction. And now we are arriving to what we are going to discuss the most part of this presentation. It's not the last technique, because I promised you that I will say a few words about all the techniques that you saw on that slide. But now we are starting to talk about what we call continuous wave technique, which is nothing more than, let's say, a better and easier and shorter vertical compaction technique. It was actually derived from the Schilder technique, but the advantage is that at some moment we were able to develop some devices that you will see that make our work much easier. And the idea is also to use a master cone that we introduce inside the root canal until the working length. Actually, if you read the books, you will be taught that you need to introduce this cone until the working length, and then you should cut like 0.5 millimeters or maybe even 1 millimeter. I don't follow this rule. I always take a cone and I introduce it until the working length. But once again, if you followed my previous webinar, you remember that I said I'm pretty sure about how I estimate the apical diameter, and even if the apical constriction is not always round or almost round, and we know that there are a lot of cases when we don't have round apical constrictions. Actually, if we approximate the minimum diameter of that constriction, we can be sure that if we take the appropriate gutta percha point, that point will not pass through the apical constriction. And now we are introducing this cone to the working length or to the working length minus 0.5 millimeters. Let's say if you worry about the possibility of overfilling the root canals, and then if we adapted this cone and we know that it's the proper one, then we put some small amount of sealer on it. I will show you after we will follow this animation. I will also show you a clinical example, and you will see how things are happening in day-to-day life. But now let's look to this diagram. So we just place a small amount of paste of sealer and we introduce this gutta percha point into the root canal. Then we come here at the entrance of the root canal and we cut the gutta percha point the same that we do in the single cone technique, in the lateral compaction technique, in Schilder's technique. So this is actually universal. This step is universal. We just cut the gutta percha at the entrance of the root canal. The only difference is that this time we use a special device. It's called heat carrier. I will show it to you in a moment, and I will explain you how does it work and actually what we expect from it. So we use this heat carrier. We cut the gutta percha. Gutta percha is very hot here. It's about 200 degrees and it's starting to cool down, but while it's still hot, we come with a cold plugger, a thick plugger, and we press here at the entrance of the root canal just to create a plug of gutta percha. We need a plug of gutta percha at the entrance of the root canal because this technique combines the heat that actually liquefies the gutta percha. So it combines the heat with the pressure, and in order to be able to get pressure inside the endodontic anatomy, we need to have a plug at the entrance of the root canal, and this plug is created by gutta percha in this phase. And then we take the heat carrier again, and just look to the animation. The things happen exactly like in this animation, but just faster. We introduce the hot instrument, and remember that this instrument is like 200 degrees. So we introduce it through the whole root canal to the working length minus 4 or 5 millimeters. So this actually, this level here should be 4 or 5 millimeters shorter than the working length that we measured while we performing the cleaning and the shaping step. So if we manage to arrive here, then we just need to stop to let the instrument to cool inside the root canal. And after 10 seconds, remember 10 seconds, we will just have to remove it. But until then, I still need to say a few words about this step. So usually we need no more than 2 seconds in order to be able to introduce this heat carrier inside the root canal. And please remember that this tip is 200 degrees hot, so it's also a little bit dangerous. And if this procedure would last more than 4 seconds, the temperature that will develop inside the root canal will be transmitted at the external surface of the root. And if we transmit this temperature, high temperature, on the external surface of the root, then we can generate external resorption, because the ligament will be affected. And if we generate this resorption, we can cause a lot of relative problems. So please remember no more than 4 seconds, but usually you need just 2 seconds to be able to traverse this distance from the entrance in the root canal to the 4 millimeters from the working length. If you are in the beginning and if you are not used with this technique, and maybe you are not so experienced with the rotary instrumentation and the taper, the different taper of the instruments, maybe it's a good idea that you will test this plugger, this heat carrier, the heat plugger, heat carrier. Maybe it's a good idea to test it before you introduce the master cone. So just test it inside the empty root canal to check that it can be introduced until the level that you want to introduce it. I will further discuss this thing a little bit later. Now, if you stayed here for 10 seconds and now the instrument is cooled down, you have to pull it out. So we just push the button of the instrument for 1 second. It's more than enough for this tip to get back again to 200 degrees. And then you just pull it very fast, not like in this animation. So you just need only 1 second to pull this tip out. And if you do this, then you come with a cold plugger and you just press here because the gutta percha is still hot. And if you come with the plugger and press, in this way you will compensate the contraction that gutta percha will suffer when it will get back to the body temperature. So you just have to press a little bit in order to compact the gutta percha there. And if you take a look carefully to the screen, now you can see that the apical part of the root canal is sealed. And if we have lateral anatomy, and be very careful, it's not enough to have the lateral anatomy, but the most important part is that we were able to clean it and to keep it permeable to liquids and now to root canal materials. So if we achieved this result, then as you can see in this animation, now inside the lateral anatomy we have sealer, but the most part of the lateral anatomy is filled with gutta percha, which is the maximum that we can pretend from a root canal filling technique. We want to have inside the root canals, as I told you, we need to have as much gutta percha as possible and only a very thin layer of sealer at the interface between gutta percha and dentin. And this is called the downpack step, like in Schilder technique. And now we still have to fill the rest of the root canal, which, by the way, you can see it's empty. It's completely empty. And you can deduce from this that when we removed the heat carrier from the root canal, it took out also the gutta percha from this part of the main root canal. So now we just need to use another instrument. It's called extruder. You will see it in a moment. This extruder is different from the heat carrier by the fact that it has a very thin tip, and this tip actually, it's a cannula, it's empty inside, and through this cannula we can deliver liquid gutta percha that is also heated about 160 to 200 degrees, and we deliver this gutta percha through this cannula, just like in this animation. And this step, it's called backfill. So we are talking about downpack on one hand, and on the other hand we are talking about backfill. And now we just need to take this time a thick plugger, of course a cold plugger again, and we just press here at the entrance of the root canal, and now all the root canal system should be filled and sealed mostly with gutta percha and with a very, very thin layer of sealer. Now I will make a little break from the presentation. I will switch on my camera. I will stop the screen sharing, and I will try to show you the devices that you saw on the animation, and to explain you what we are actually doing with them. First, I need a short test. I need a short test from your side. Just tell me if you can see the instruments, and for example, if you can maybe, I don't know if you can read what's written on them, but at some moment I think the camera will focus. But still, if the quality of image is good enough for what I'm going to explain next. Hello, Alexandra, welcome. Darius already managed your request. Nice to meet you. Okay, so some feedback about the quality of the image that you can see here. For example, can you distinguish that here is the M letter at my finger? Some people don't see letters. Some people say it's good quality image. It depends also about how the camera focus. Now I think you could see for a few seconds, you could see that there is an M letter here. Yeah. Let me try something else. I think it's a little bit better now. Okay. Let's start. So, if you want to do continuous wave techniques, actually these are the devices that you need to have in your office. I mean, not really necessarily these ones, but today our hosts are the KaVo Care company. So of course I will talk about this device that it's called Element IC. And these elements IC, like any other wormwood aperture device, has two components. This one, the shorter one, is called the heat carrier, and this one that is longer is called the extruder. So first we will talk about the heat carrier, because the heat carrier is the first that we use during this technique. But before we start talking in detail about these instruments, I just want to make some general to say some general ideas about them. You can see that they are wireless devices, and they are charging electromagnetically. There are no wires here. There are no connections. It's just the instrument that you place inside this base. And I think this should happen with all the devices that we use in our dental offices, because now we have the technology, and this is the most appropriate way that we can disinfect them, and we can use them properly. Of course, the base has a connection here on the other side. You can see there is a plug, and here you connect the power cord, and through this base you can charge the instruments. Of course, while you can use these instruments for 2 or 3 or maybe 5 treatments without charging them. But my recommendation is that you will keep them inside the base when you do not use it. I mean, during the treatment, you will have them on the working field, but after the treatment, you just have to use them inside the working base in order to always have a fully charged battery. Now, I promised you that we are going to talk first about the heat carrier. So this heat carrier have a tip. This tip looks like this. You can see here, I think now you can distinguish the text. It's written Cybron Endo. And I will take advantage about this moment to tell you a little bit of history. I think the name Cybroendo is very popular among you, especially to those that love endodontics very much. So the Cybron Endo company was a very known company among the endodontists, and this company a few years ago, there are almost 10 years now then it happened. It was bought by the Care company, and then the Care company just got together with the KaVo company, and now we are talking about the KaVo Care brand. And inside this KaVo Care brand, there is the Care Endodontics division, and all the Cybron Endo instruments and spare parts and consumables that you found under the Cybron Endo brand, you can find now under the KaVo Care if they are still produced, of course. So this system actually is a system that was derived from the old Cybron Endo root canal filling devices, and still the tips are the ones that were used with Cybron Endo devices. And this system, you will see that have not only one tip that I showed you, but there are 5 different tips. I will put them on the next slide, and I will explain you everything you need to know about these tips. But in the beginning, I just want you to take a look at this connection thing. It's like a hexagon, and also this tip has a hexagonal profile. So actually you can place this tip in 6 different positions around the instrument. I think from my point of view, this is not so important anymore. It was very important on the old devices, because these devices had a button here and you should press a button in order to hit the device. Now there is this round rubber thing, because I cannot call it switch or button, and wherever you put your finger around this rubber, you will start the device, hitting the device. So I think the position of this instrument, of this tip, is not so important anymore. What is very important, in order not to break the tips, because they are not very cheap, of course they don't cost a fortune, but still we don't want to damage them before we completely took advantage of their use. So just push the tip until you feel it cannot enter anymore, and then switch it a little bit left and right and just press it. So you don't have to screw this tip. If you will try to screw or unscrew the tip, you will just break it, because this round part with the hexagon here on the back, this is bonded on this central thing, and if you rotate it, you will just debond it, and the tip will be no usable anymore, or it will be very difficult to use it. Then what you also need to know is that this tip can easily be broken if the dental assistant doesn't know how to remove it from those sterilization bags. You know that there are those sealed bags, and if you want to take something, usually we just perforate the paper part of the bag, and we just pull out the instruments that we want. If you will use this part, this end part here, that is also bonded to the central part, and if you will use it to press on the paper and to break the paper with it, at some moment you will end that you will break the instrument. You will actually jeopardize this bond here, and if we jeopardize this bond, then the instrument actually will get unusable. So you really need to take care how you manipulate it, and to train your dental assistant how to do it. By the way, about 2 weeks ago, or maybe 3 weeks, I had a webinar, also a free webinar, about how to manipulate and how to do the maintenance for these devices, and not only for these devices from KaVo Care company, but almost for any similar device that you will find on the market. And if you feel this information, if you think this information is interesting, I will just pass you my contact data at the end of the presentation. Please write me the email, and I can send you a link to that webinar. the English version of that webinar, or if you want the Romanian version also, and you can watch that information also, and you will find more tips and tricks about how to manipulate, strictly how to manipulate, not to do clinical procedure, and also how to do the maintenance of these kinds of instruments. Now, in order to start this instrument, we have this button here, I mean the lower one, and I will press it for 3 seconds and for 2 seconds, sorry, and you can see that this screen was started, and also you can see that here it's written gutta-percha. On your left side of the screen, you can see a battery diagram which is full. It says that my instrument is full and ready to work. And also you can see that it's 200 degrees temperature written here. This is actually the temperature that we use the most. But what is special to this device is that we can change actually the temperature, and it's not that we can change it to a lower temperature, which usually I do it, and I will explain you why I use lower than 200 temperature while I perform this technique. But what is interesting in this device is that you can also use it as a how to say, thermal cutter for the gums, for dental papilla, for example. So just remember, it's not electrocauter, but it's a thermal cauterization. And if you do that, just remember to use the thickest tip that you have available. Because if you will use thin tips with so high temperature, you will end up breaking the tips. So remember, the higher the temperature, the thicker the tip should be. If you are forced to use, for vertical compaction, if you are forced to use thin tips, then remember always to reduce the temperature if you want to have these tips for a very long period of time. Of course, these tips have some stoppers. I will talk about these stoppers, but if you remove it and you just lose it, it's not so important the color of the stopper itself. So just remember, it's the default temperature is 200 degrees, but usually we use a smaller temperature like 170 or 180, because we don't need so much heat inside the root canal, and because we also want to preserve better these tips. If we need to use it as a thermal cauter device, then we will use the thickest tip that we have. The second device, as I told you, it's called the Extruder. Maybe some of them heard about what we call Obtura Spartan. Obtura Spartan was the first company that delivered on the market a device that was able to produce liquid gutta-percha. And you remember that, and we still have Obtura Spartan on the market. If you remember, the shape of that instrument was, and it still is, like a gun, like a pistol. Well, this was quite an efficient device, but when we talk about ergonomics, I'm not very happy with that shape. I have, in the offices where I work, I have both this thing and the gun shape one. I think both of them have advantages and disadvantages. I detail these advantages and disadvantages in the other webinar that I was talking you about. I will not have the time for comparison, for comparing them this evening. but still from the ergonomical point of view, I always prefer this one. First, because it's wireless, but now we have also gun devices that are wireless. It's not because the wireless, but it's because of the shape, because you can use it also ergonomically like you use the other device, and I'm talking about the heat carrier. So this extruder has 3 buttons, not 2 like the previous one. This one here actually starts the instrument, and now I will stop it because I don't need it started right now. The one in the middle, it's like a refresh indicator. It's like a circular arrow, and this deals with the piston. We have a cylinder here, I will show you in a moment, and we have a piston that push inside that cylinder, and at some moment we want that piston to get back, and this is when we use this middle button. And also the one on the top, it's also an M letter like on the heat carrier, and this is the button from which we use to change the temperature, because we also use this device at about 200 degrees, but sometimes we only need like 160, maybe 170, and we can change that from the settings. What is the most important part of this instrument is the tip, because this is the one that delivers the guttapercha through this very thin cannula that you can see here. And the guttapercha, it's inside this very small cylinder where you can see this plastic blue ball. Actually, once again, in this cylinder, we have the guttapercha. And this is disposable. It means that when you finish the guttapercha inside this cylinder, you also throw away the whole tip and you get another one that is full with guttapercha. You need to be very careful because these tips are quite fragile. You can bend them, but you should do it very, very in a very, very delicate way, because they can break. And the most frustrating way of breaking these things is just to touch them. Usually the dental assistant does that when she moves through the dental office. She touches with maybe with the uniform, with the hand, or maybe with some other instrument, and they manage to break this tip. And if you break it before you use the guttapercha inside this cylinder, then it means that you actually throw your money on the window. So we need to really be very, very careful with these devices. Otherwise, it has a very, very good advantage that you change very often the tip. So from the point of view of the cross infections, even if you don't change it every patient, if you take in consideration that actually you do not end working with it inside the mouth where you have saliva and blood, you have the rubber dam, and you use it at the end of the treatment, and you use it only usually only in a small part of the main root canal. So actually it's not a very, very high danger when we are talking about contamination. Still, we need to be careful. This one you should disinfect after each patient, so you just clean it as you clean your hand pieces or your air and water spray. And actually this one is autoclavable, so you just remove it from here and you can autoclave after each patient. Now it depends how many of these you have inside your dental office. From my point of view, I have a lot of these tips and I autoclave after each patient. But if you cannot afford that, I think this one can also be disinfected like you do it with your handpieces and with the surfaces of the dental unit and of the place where you keep some other instruments. Because if you don't use it for cutting the gums, I mean like a cauter, like a thermal cauter, if you use it only for root canal filling, then there is no danger of cross-contamination. But remember, if you want to use it as a thermal cauter, you should always autoclave it before and after the procedure. So these are the instruments that we are going to use and you are going to see in the next clinical example. What you still need to know about this this extruder are some more details. For example, if you need to change the tip because it ended and you are during a procedure, if you want to remove it, remember that this part is like 200 degrees hot, and we don't want to have fingers on this metal side here. We only want to keep it like this with 2 fingers and only manipulate it from this plastic part, because remember here we have 200 degrees. Another important thing about it, and now I will start the device because I want to show you something, and I will show you first, and then I will carefully ask you to to listen to some noise, and I will put the instrument near the microphone. But in the beginning, just look to this light, to this blinking light. Until this light is blinking, it means that the gutta percha inside the recipient, inside the cylinder, is too cold and you cannot use it. We need to wait until this LED will start blinking, and when this will stop blinking, now we actually can use it. And if you can see now, if I press this round piece of rubber, we get a blue light here. It means that we started to extrude gutta percha through the tip. And now I just want you to see the same thing when we are talking about the heat carrier. I will start the device. Now we don't need to wait, because this device, when I press here, the tip instantly gets to 200 degrees. And now just listen. I will make silence and just listen to the noise. I think you can hear a sound, and now you see that the LED, it's still blue, but you cannot hear that sound anymore. This is called the 4-second protection. So now even if I have the finger on the switch, I can touch the tip because it's completely cold. And this is the protection that prevents you to hit the periodontal ligament. If you keep it more than 4 seconds, it stops by itself. And now I want you to listen to some other noises. I will just hit the instrument, and now I put it near the microphone. You heard the beep, and now you heard 2 other beeps. This is the way the instruments lets you know that it passed 5 seconds and then 10 seconds, because you remember that you have to keep this instrument inside the root canal for 10 seconds in order to cool down, and after it cools down, only then you should remove it from the root canal. So this is the way the instrument tries to help you in order not to keep an eye on your watch and to count seconds. And also it helps you not to hit the periodontium too much if you forget about those 4 safety seconds. And now let's get back to the presentation. I will share the screen again. Please allow me just 5 seconds to stop these devices because they are hot. And now I stop them. And we can get back to the presentation. I promise you that I will talk about the heat carrier tips. Can you see the presentation on the screen? I think everything is okay now. And these are the tips of the heat carrier. This is the moment when after 15 minutes at last webinar, people started to write me that they cannot see me. They can only see my hands. So now I switch also the camera on my face. Now let's talk about these tips. You can see, and I anticipated, we have 5 such tips with this system. They differ. If we talk about other manufacturer, maybe their system have only 3 or 4. As far as I know, 5 different sizes is the maximum that I met with one producer of such instruments. And what is important to know about these tips is why they are different, because you can see that some of them are thinner and some of them are thicker. And it's quite confusing because also the annotations on them are a little bit confusing. So I just want to make everything clear in order that you will be able to distinguish these instruments. So if you look to the big screen, let's start with the instrument in the middle. This one that have a green stopper. I don't know how good the colors are on your screen. I think the blue and the purple are very good. Also the red. So this one here is pink, and this one here in the middle is green. And this green one in the middle, if you can see, and I think you can distinguish, it's 3004. It means that the tip of the instrument is 30 hundredths of millimeter thick, and also the taper is 04. Just remember that this is the most different one from all the others because the tip is different. It's 30, and also it's the only one with the 30 in the tip, and also the taper is 04. It's the lowest taper. Now all the other fourth that remained, all the other 4, actually, as you can see on the right slide here, on the right picture on the top of the screen, their tip is the same. It's number 50. So it's a half of a millimeter thick. And all these instruments, all the 4 except the middle one, all the other 4, their tip is the same, 50 hundredths of millimeter. What's different is their taper, and it starts with 6, taper 06. So this one was 04, the 30. This one, the red one, is 06. The blue one here is 08. This one is 10, and the greatest one is 12. And also, I think you can distinguish here some letters, except the middle one that has no letter. So this one, what you can see on it, it's 30 and taper 04. All the other 4 instruments have no number for the apical, for the tip, because we know that the tip is the same, is 50 hundredths of millimeter. And instead of the diameter of the tip, they have a letter. And this one, which has the smallest conicity, the smallest taper, is F from fine. The next one is fine medium, FM, and taper is 8. This one, taper is 10, and it's medium, M. And the greatest one, taper 12, is ML, from medium, large. And now I think you can make an idea about these annotations that you can find on these tips. And also you can distinguish that the thinnest one is the one in the middle. And whenever you perform a conservative endodontic treatment, you should use the one in the middle. And while you are performing, let's say, cauterization, then you will need this one, the greatest one. I mean the ML instrument with the 12 taper. This is the webinar I was talking about. So if you want the link to this webinar, this is the Romanian version that we had 2 or 3 weeks ago. So we are talking about not only this device that you can see here, but almost everything you can find on the market. And we are discussing the advantages, disadvantages, and the most important thing, what you should do to correctly manipulate them and how to maintain them while not working with them. Of course, you do the same that we discussed. You do the downpack and the backfill with them. So if you would like to see this recorded webinar, then please feel free to contact me. At the end of the presentation, I will show you the data. Now, how we perform this root canal filling technique. Now, we start with the root canal sealer. And when we talk about root canal sealer, I just want to make a very important comment. You see that we have a small quantity of colored material, this brownish material. And if we are talking about the white part, it's a little bit more. This is a common mistake that I encounter in my day-to-day practice. Dental assistants or even my colleagues try to express equal quantities from both parts of this kind of sealer, which is not right, because even if you look to the tube, you will see that the two cannulas that deliver the paste are different in thickness. So if you look to those cannulas, you will see that from the beginning, you just need to express less colored paste and a little bit more white paste. And then we just spatulate this material, and we need to be very careful to incorporate all the material and to obtain a homogeneous composition. And then we just take the gutta-percha points, and as you will see, we just put some very, very, very small quantity of sealer on the gutta-percha point. And actually, this sealer is all that we need through the whole procedure. So this is the way that we reach that aim, that we are going to have inside the root canal as much gutta-percha as possible, and add as a small quantity of sealer as possible. And after we place gutta-percha on the paste on the gutta-percha points, we introduce them inside the root canal, and now you can see the downpack step. This is actually what happens in the day-to-day practice. I don't know the quality of the video. Unfortunately, this platform is not the best platform for showing videos to participants, but I hope the quality of the video is good enough in order to understand what are actually the clinical steps of this procedure. Somebody says that cannot see any video. Is this the situation with everybody? Can you give me some feedback, please? Can you see the video? I will just stop a little bit. It's lagging. Yes, I know that it's lagging, but it should be some video. I stopped it now, and now I will start it again. So as you can see, when you do the down pack, you just remove the excess of gutta percha with the heat carrier, and then we push with the plugger in order to compact the gutta percha in the 4 millimeters apically. Now I just want you to be very careful to this part. Now, because we are compacting the gutta percha in the distal channel, in the distal root canal, you will see that when I remove the carrier, the gutta percha remains there. And this usually happens from two reasons. And now the reason is that this root canal has some retention surfaces. And actually you saw that when I came with the cold plugger, I was able to remove all the gutta percha that stayed there inside the root canal. So whenever you encounter this problem, that you make the root canal filling and then the gutta percha remains there and it's not pulled out with the heat carrier, you just need to wait for the gutta percha to cool down, and then with a cold instrument like a plugger, you just take it outside the root canal. Unfortunately, sometimes this accident happens because the root canal is too thick and you do not have such a thick tip for the heat carrier. And in that situation, you just need to take a thicker tip for the heat carrier, because otherwise you will not condense the gutta percha. You will just pass with the instrument through it, and that's all. You will not get any pressure, and the compaction you will not be good enough in order to feel the lateral anatomy. Now you can see the backfill step of the root canal filling, and we filled the distal root canal, and now we still have to fill the mesial canals. This part you can do it on one movement, and we call it backfill, as you can see here, or you can do it in steps, like incremental steps of 2 millimeters of gutta percha, and then it's called backpack. But if you do not use magnification in your day-to-day practice and you just use naked eye or sometimes loops, which are not always enough for endodontics, then I advise you to do it in one movement. So just do the backfill, not the backpack, because if you do not have a good visual control, then it may happen that you will have a lot of voids inside the root canal. What we can also see is that I try to work as clean as possible. So you will not see a big quantity of gutta percha or a big quantity of sealer in the pulp chamber. I try to work as clean as possible because I don't like to waste the materials, and I don't want to lose time in order to clean the pulp chamber's walls, because you know that after finishing the root canal filling, we need to do adhesion and to fill the crown, and we need those walls as clean as possible. You can see here another example of the gutta percha that will not leave after the down pack, step. You see the heat carrier is just out and the gutta percha is still inside the root canal, and you can see that this canal, as it very often happens with the distal canals of the molars, have two retentivities, one on the buccal side and one on the lingual side. And we need just to take that gutta percha with a cold instrument and carefully pull it out. Sometimes it works easy, sometimes it's a little bit more difficult, but still we need to try to remove that gutta percha, and then we can start the backfill with the extruder device. Another example, this time we are talking about an upper premolar, and this upper premolar have two root canals, but these two root canals actually communicate, and this isthmus is a retentive part, and you saw that the gutta percha was fixed there, and I had to remove it manually by using a cold plugger. Now I come to a topic that is generated by a question that I encounter very often in my hands-on lectures. And the general question that I receive is how much this procedure costs, and how expensive is to use these disposable tips for extruders. And actually the most addressed question is how many root canals can you fill with one cartridge? And my answer usually is received very skeptically by the audience, and even by the sales agents from the KaVo Care company, and even from the producer itself, because I pretend that with one tip I do at least between 10 and 15 root canals, while the manufacturer recommends that they are used with 4 to, let's say, 6 or 7 root canals. And I have an explanation for that, and I will pass it to you. And I also made a simulation with numbers, so you will better understand how you can preserve this gutta percha. Because of course it's not such a big amount, but in Romania such a tip costs about €4. And if you think that with €4 you will feel like 4 root canals, we have, from my point of view, quite a big price for the filling of one single root canal. But fortunately, I think we can use this much more efficiently than even the producer recommends, and I will explain you how we usually waste these materials. The first mistake that a lot of people do is when filling the single rooted teeth, especially the anterior teeth that have very large pulp chambers. And with these teeth, it's very difficult to establish where is the borderline between the pulp chamber and the root canal. If we manage to succeed in keeping the root canal filling just inside the root canal and not inside the pulp chamber, this way we will save a lot of material, because you know how big the pulp chambers are in the anterior teeth, especially in younger patients. So first thing that you need to have in mind is not to waste the material on surfaces and on places where we should not have gutta percha. The pulp chamber is for adhesion, and there we just use composite materials, not gutta percha and sealer. Now, I just want you to look to some numbers. I made a simulation. This is geometry. I will not show you how to make the calculation. But if we approximate the root canals, and if we imagine that they are round in section, of course, they are not perfectly round, but we can do this kind of approximation. If we prepare them, let's say rotary, you have on this column a simulation of a root canal that is 20 at the apical constriction, and it's 0.4 taper, and on that side, on this column, you have the same root canal with 20 at the apical constriction, but with 0.6 taper preparation. And now let's see how much volume of gutta percha we use inside these root canals. What I colored in yellow are the first 4 millimeters, which are not affected about the extrusion, about the backfilling part, because here we are doing the down pack and we have the master cone. So we are talking only about green side and red side. And if you look to the numbers, both for the 20 with 0.4 and 20 with 0.6, if we count the volume of gutta percha that we used in these 6 millimeters, 1, 2, 3, 4, 5, 6, you will see that it's almost the same with what we used during last 3 millimeters. And the same is with 0.6. If you count 1, 2, 3, 4, 5, 6 green millimeters, it's less than what we used during last 3 millimeters of the root canals. So imagine that all of us will respect the recommendation that when we perform the root canal filling should end 1 or 2 millimeters deep inside the root canal. Just imagine how much gutta percha we could save if we just follow this simple rule. And despite the gutta percha that we save, we can also talk about the surface that we earn for the adhesion, for bonding the composite. So from both points of view, it's better to save gutta percha, both for not wasting the material, but also for having a much more surface for adhesion. What usually happens in our day-to-day practice, I think you saw on my first slides of this presentation, you remember those teeth that had a lot of gutta percha inside the pulp chamber. That is waste of material and also waste of surface for adhesion. But let's just make another calculation. Just look through these 3 millimeters here on the right. So the 1, 2, 3 millimeters on the red part of the 0.6 root canal. If you count them, we have 1.8 cube millimeters, almost 1.9. And if you carefully look to what we have on the left side, you can see that we can easily fill with only these 3 millimeters that we, let's say, wasted on an 0.6 root canal, we can fill the whole 0.4 canal. So just with what we gain from these 3 millimeters. So when asking how much root canals you can fill with only one single tip of the extruder, first of all, you should think about what kind of endodontics you are treating. If you are a conservative guy, or if you treat more vital cases than retreatments, then your preparations will have a smaller taper usually. So you will be able to fill more root canals with a small amount of gutta percha. If your day-to-day practice is based only on retreatments and you use a lot of rotary instruments and you even use Gates Glidden burrs, then expect that in the root canals where you don't place posts, you will waste a lot of gutta-percha, and you need to be prepared for that. By the way, if we are talking about continuous wave technique, one very, very big advantage of this technique is that if we want to place a post inside the root canal, we can do that actually, immediately. When we finish the root canal filling procedure, we don't have to wait for sealers to set. Just we need to anticipate how deep we will place that post, and simply we will not fill that root canal with gutta-percha, so it's much more easier. That was vertical compaction, actually continuous wave technique. That is, let's say, a variant of a vertical compaction. And now I will just say a few words about what we call squirting technique. This squirting technique means just using only the extruder. So we just use liquid gutta-percha for filling the whole root canal. From the beginning, I have to say that I don't like this technique. And I will tell you why. It's the technique that has the lowest predictability. We can do a lot of mistakes if we are not very well trained in that technique. Actually, I only use it in the root canal where I have very, very big discrepancy between the diameters of one root canal. Imagine, for example, a distal root of a lower molar, which has a very small diameter in the mesiodistal direction and a very, very big diameter in the vestibulolingual direction. Well, in that case, I take in consideration the squirting technique. Otherwise, I consider it too dangerous and very unpredictable in order to use it in my day-to-day practice. You have here an example of a lower molar, a second lower molar with only one root canal. So the whole molar have a root canal like it had the pulp chamber from the crown to the apex of the tooth. And in that idea, I decided to place some MTA apically because it was also a very large apex. When I do that, I never use MTA carriers. I just use, as you saw, I use pluggers. I got used to that from my beginnings in endodontics because I did not have access to high quality MTA pluggers. So that's why I trained very well to work only with the hand pluggers. And then after I place the MTA and the sealer, I just come with the extruder and I fill the whole root canal only with gutta-percha. Of course, this situation is the most consuming example of gutta-percha from the extruder. So if you have concerns about the costs of the root canal fillings, actually this was a very costly one, because probably with the gutta-percha that I consumed during this single root canal treatment, I could fill maybe 6 to 10 very, very small root canals in vital teeth. So this is what I was talking about. Here we have a very huge amount of gutta-percha, but this is a particular situation. Thanks God, we do not face this in our day-to-day practice. One of the last techniques that I would like to talk about, it's not the last one, but is the one before the last one. It's what we call, sorry, this is in Romanian, I forgot to translate it. It's a carrier-based gutta-percha technique. Actually, we have a carrier here, a plastic carrier, and this is the one that carries the gutta-percha. In essence, it's quite similar to continuous wave technique, the downpack step, just that the carrier stays inside the root canal. I don't like this technique because it's quite unpredictable. You need to be very well trained, because if you push too hard on this carrier, you may wash the whole gutta percha from the root canal, and you will just have directly plastic against the wall, which is not the best case, because we will not have seal anymore. On the other hand, it's quite an expensive technique, and the benefits that it brings does not justify the price. So if you are interested in this technique, you can write some questions, I can answer, but I'm not a fan of it, and I think I explained you why in a few words. A very interesting technique, but also quite a risky one, is what we call the McSpadden technique. Is when we use a very small amount of sealer and the gutta percha point, and actually we hit this gutta percha point and we compact it with what we call a thermocompactor imagined by Dr. McSpadden. And this is used by an endomotor, and you can see that because of the temperature and of the pressure, you can see how the sealer and the gutta percha are extruded even through some lateral canals. So this is called thermomechanical compaction, McSpadden, and we use a special rotary instrument, let's call it maybe rotary file. It's called McSpadden compactor or thermocompactor or gutta condenser. You can find it also on the market. I'm not also a fan of this technique. It looks interesting, but I think it's a little bit dangerous. Still, it's much cheaper than other similar techniques that uses pressure and gutta percha. So let's make a final review. We are talking about all these techniques, but as I mentioned, I advised you to adopt one of these green ones, either the single cone technique or the continuous wave. I explained you that the single cone technique could perform very well if it's correctly done, but you need to take in consideration that you need to get used to work with higher tapers. And if you want something superior, that is continuous wave technique, which I will not say that it will bring a very, 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 let's say, huge advantage against the single cone. But if you want to address also to the lateral anatomy, then this one, it's the single, our single option, because it's the most predictable one. It's not so expensive, and still, as I told you, it also addresses to the lateral anatomy. And these were my conclusions. I just have to thank you that you are still here with us, and you watch the whole presentation. This is my contact data that I was talking you about. If you have questions that you will remember maybe tomorrow or maybe next week, I don't know, or if you want the link for the English version of the webinar I mentioned, the one with the maintenance and manipulation of the root canal filling devices, please feel free to send me an email or contact me on Facebook and or on LinkedIn, and I will answer you. I'll be very happy to answer you. Also, you can contact Darius for any other technical problems. And if you have some questions, now it is the moment to write them here. And if if I know the answer, for sure I will be very happy to deliver it to you. I will just stop the presentation, and now I will just share the webcam, and I will just look for a few more minutes to the chat. So if there is somebody that wants to ask something, please feel free to ask. In the meantime, I would kindly ask Darius to tell us a few words, if he is still there, and I think he is still there.
I'm still here.
Great, Darius.
I'm impressed as usual. So this is your fourth webinar I'm hosting. So I'm really impressed, and thanks to all participants, all attendees who have managed to, let's say, stay with us so long. Thank you, and I hope we'll meet you soon on next webinars. Thanks a lot. Enjoy.
Thank you very much. Darius, please tell the participants where they can find information about the other webinars that you organize, because there are a lot of other international speakers that will have webinars these days. So maybe people will be interested in those presentations also.
Exactly. You can find information about webinars on Facebook, on KaVo Facebook, as well as you can send me email asking for a program of webinars. I will send you the program with links associated, so you can register.
Maybe you manage to place the link to the KaVo Care account's Facebook page. Maybe you can manage to place the link here. It's if you have it somewhere and it's not
in a second. So I will. I just need to open it, and
because
I will put it.
it's easier for everybody. And there, guys, you will find much more information
Convenient,
on
yeah,
other topics,
more
not
convenient.
only endodontics necessary. Thank you everybody for being here with us. I hope the presentation met your expectations. I have to announce you that I will have I planned some other webinars regarding endodontics topics. They are mainly in Romanian language, but if you are interested in some topic, some specific topic, please write me an email, and I can make some of them, even the either the recorded version or maybe a live webinar. I can also make them available in English. I don't know if you are interested in retreatments, or if you are interested in restoring endodontically treated teeth, or whatever you are interested in. Just feel free to contact me on Facebook or on LinkedIn or WhatsApp or email. Just write me your ideas, and if possible, I will be very happy to prepare some new topics for you. Thank you, everybody. Thank you, Julia. Thank you, Florin. Thank you, Silvio. Thank you, Roxana. Thank you, Charis, and all other colleagues that stayed with us until this late hour. And I hope we will meet very soon, maybe with some other occasions like webinars, but I hope this coronavirus stuff will end very soon, and I hope we will be able to meet again in our hands-on lectures, because despite the fact that these live webinars are very interesting because you can reach a lot of people very easily. Of course, the face-to-face and one-to-one lectures could not be totally replaced, but by these kind of activities. And as I told you, I hope we will be able to meet in a very, very short period of time. And now Darius have the link for the KaVo Care page. So if you follow that page, you will find information about all the webinars that they organize. Um, some of the lecturers I know personally, and they are very good speakers, and they have very interesting topics. Some of them I don't know them, and I'm very fond to hear them and to find new things from them. Um, from this moment, I think we can come to an end now. I thank you all for being with us until this late hour, and I wish you to have nice days that I think you spend with your families and your relatives these days, because at some moment we will go back to work, and I think we should take the most advantage that we can from this situation. Thank you once again, everybody. Darius, I think we can declare this session finished, and let's meet to the next webinar.
Okay, then. Thanks a lot. Thanks a lot to the audience, and hear you soon.
Have a nice evening, everybody, and good night.
Good night.